And the third presentation comes from Spain, and Jorge Alio is going to share a new method of aberrometry, open field aberrometry for refractive lens surgery.
Hello, my name is Jorge Alio. I want first of all to thank for the kind invitation Dr. Pavel Stodulka to participate in the Prague Ophthalmology Festival sponsored by POF and AECOS. My topic today will be open field aberrometry, which is a new tool for refractive and lens surgery. I'm talking to you from Alicante, Spain. These are my financial disclosures for the topic of this presentation, and I declare that I am consultant of CSO. In this presentation, we shall talk about traditional devices, accommodation and vergence, measuring refractive errors and accommodation on traditional devices, open field devices, off-axis measurements, PWS working principle, and clinical cases, finally, and conclusions from my experience with this technology. Let's have first a summary about measuring refractive errors on traditional devices. How do they work? We need to consider that usually primary light source is near infrared and secondary is backscatter light from fundus. The near infrared light is sufficiently back reflected by the fundus, and the most common working principle for refractometers and barometers are the following: Steiner principle, autometric principle, best focus principle, focal edge knife principle, in which open field aberrometry is based, ray reflection principle, which is the one with Harman-like sensors, and image size principle, that all of them in one way or another have been used for this purpose. In refractive errors on traditional device measurement, the patient is seated in front of the refractometer or aberrometer looking into the device, and the measure starts. There is an internal fixation system that provides help controlling the patient's fixation and accommodation. And such devices are usually using the fogging technique to relax accommodation before the jetty refraction is taken. Accommodation is relaxed either when prominent feature presents low spatial frequencies, the scene has wide band of spatial frequencies for observation, or more frequently when the scene mimics one scene at distance. Is the process by which the eye regulates the focus. This process is called accommodation. There is a functional goal, which is to obtain clarity of vision at any distance, and accommodation usually acts as a reflex, including part of the accommodation vergent reflex, but it can be also controlled consciously. Mammals and other reptiles and other creatures use different types of accommodation that are obviously different to the human being and the mammalians. Accommodation is following this scheme. You can see here that when you have a neuroptical blur, you are affected by the depth of focus, and you have a tonic accommodation that is completed by accommodation controller. Then the ciliary muscle and lens is active, and accommodative response is induced. The step from accommodation control to ciliary muscle lens is called CAC relationship. When we have a fixation disparity, we stimulate the Panos area in both eyes. Then we have a tonic vergence that is overstimulating the vergence controller, creating an action in the structural muscles and creating a vergence response. The relation between vergence controller and the structural muscles is called ACA relationship. Current models of the cross-coupling between accommodation and vergence are represented as negative feedback systems. If a target is moved closer to the eye, a symmetrical change to both accommodation and vergence occurs simultaneously because of increased blur and close disparity. Disparity-driven vergence signals influence accommodative output, and similarly, blur-driven accommodative signals influence vergence output. Measuring refractive errors on traditional devices is affected by some bias. As you can see here in the image, we have the target at optical infinity that is perceived at near. And this perception at near of this target makes the accommodation controller to be active in an inadequate and not coherent way with the distance, activate the ciliary muscle action, and far distance measure is often affected by this process by the actual device proximity. This is called traditionally as instrumental myopia. Fixation disparity is not happening in this case because you are only using one eye, and so all the divergence system is not working in this system. This is the way in which CAC relationship and divergence are excluded from the control of the measurement. Divergence accommodation conflict happens when your brain receives mismatching cues between the distance of a virtual 3D object, which is vergence, and the focusing distance accommodation required for the eyes to focus at that object. Due to the vergence accommodation conflict, traditional devices provide an invasive measurement for far vision refraction and accommodative response as well. The problem to solve is how to create a fixation system that mimics a real object in space at a predetermined distance, and such that vergence accommodation and distance perception are not in conflict. This is the problem to solve. And the solution is to use a fixation system that is representing a real object at a predetermined distance in the space. The open field aberrometer OSIRIS is used to measure static and dynamic aspects of near and far vision in a physiological non-invasive environment. It is composed of an open field viewing area for subjects, a device head mounted on a base for the eye alignment, and a computer stored responses for further analysis. Binocular vision is respected while measuring, and real-time measurement on a wide pupil side is provided as well. In this way, the fixation device is not visible. It is perceived by the brain as happening in distance, and so the CAC relation is kept, and the accommodative response is proportional to the distance. Binocular vision is happening because fixation disparity is stimulating the Pando's area, and you have the full feedback that leads to a vergence response in different distances. The working principle of the OSIRIS considers the retinal plane and the pupil plane. The retinal plane is represented in red and the pupil plane in blue. In this system, you have full illumination of all the quadrants by the system. If you use a pyramidal wavefront sensor, in this case a pyramidal device optic, the light is divided in 4 quadrants that have equivalent weight in terms of light intensity and energy. But in the metropic eye, you can represent this in a way that for the 4 quadrants A, B, C, and D have the same intensity of light and are proportional in the identical terms. When you work in the myopic ray, the conjugate plane that is created by the pyramidal lens create A and B to be equal, but less than C and D. You can see here that it happens both at the conjugate plane and on the plane of the retina. In the hyperopic ray, you have just the opposite, and A is equal to B, but is larger than C and D, and this is characteristic of the hyperopic eye. We go from light intensity that are represented in the 4 quadrants to the slope calculated by the adequate mathematical analysis, creating different pyramidal steps with the Schottky polynomials or any other way to analyze the light and to decompose it in the different aberrations that happens in the system of the eye that is explored. Refractive error map is created as well, deducted from the previous information. Let me show to you some clinical cases. In this hyperopic non-presbyopic patient, you can see how in the normal OSIRIS measurement, you get almost an emetropic condition with a relatively low amount of aberrations that are happening in this patient when measured for far. While in the OSIRIS, you see that this measurement for far is taking the real refraction of the patient for far, and the aberrations induced are usually larger because of this reason. Let's show to you how is a hyperopic non-presbyopic patient. In the left, we have the OSIRIS for far, while in the left, we have 40 centimeters, both measured with the open field analyzer. You can see how for far, the open field analyzers offer the real refraction of the eye with the real aberrometric measurements, and for 40 centimeters, the accommodating response is neutralizing this far distance refraction with the consequent induction of aberrations as happens in accommodation. This is the way in which this device, the open field analyzer, measures accommodation at different distances. We can study as well the optical quality of intraocular lenses. Look here how it's a patient with a premium monofocal IOL, which is in this case the PBT, and how is in the open field analyzer the total aberrations that are happening for far and for near, which are equal. This is the OFA without the higher or with only the higher order aberrations and eliminating the second order. You see here that the quality of the retinal image is definitely very large. Here with that trifocal size lens, you have the open field analyzer of Osiris with the total aberrations, with the typical blur or a relative defect that happens in this eye. When we eliminate the second order, you can see how the optical quality of this lens is really excellent, as good as the previous one, thanks to the elimination of the refractive error. In this way, the system offers to you the opportunity to manipulate the profile of the total aberrations, eliminating the second order, which are the ones that can be corrected by glasses or by refractive surgery, and to leave the real quality of retinal image for far that offers that system. In summary, open field aberrometry is a new tool in refractive surgery. It's a new and better approach for the study of accommodation and refraction. It's a better approach for the study of aberrations and wavefront-guided excimer laser surgery. It is a further step forward in the understanding and practice of refractive cornea and lens surgery. And finally, it's a further step forward in the understanding and use of premium intraocular lenses. Definitely, it's an important tool in refractive and intraocular lens and lens surgery. Let me offer to you this course, which we have in our university. It's an online activity on refractive corneal lens surgery with 500 hours of teaching activities in multimedia format, full in English, that will interest a lot those of you that are following an educational program in these subspecialties. Thank you very much for your very kind attention, and thank you for this invitation to participate in the Prague Ophthalmology Festival. Also to AECOS, the American European Council of Ophthalmic Surgery, for the invitation to participate also in the discussion that will follow. Thank you very much, and if you need any further information, please contact me through my email. Many thanks.
Thank you, Jorge. That was a very interesting presentation full of mathematics. I think it's a bit challenging for the eye surgeons. So congratulations, and I open the discussion.
Well, let me just say that this is just at the beginning of a new story, because open field aberrometry is the way to analyze aberration, and especially to measure accommodation, which is, in my opinion, the most important, remarkable way in which we can understand this new way to study the visual function, and especially the aberrations that are induced by accommodation. But this is really fine. I'm open to any question. Happy to receive them.
Thank you. Jorg, I'll just make a comment. I had the Osiris in my clinic for a couple of years while we were doing a trial. In fact, I think Pavel was part of the same trial, always worked in something similar, and that was for corneal inlays. We were working with an allogenic corneal inlay and using the Osiris to measure the impact. And I am blown away by that device. I've never seen such a fantastic wavefront analyzer. And we used it on multifocal IOLs. You could see the rings in the IOL. You could actually see floaters live moving across the field. So it's a remarkably accurate device. And the only reason I never kept it after the study was I was so frustrated by the fact that I couldn't use that device to drive a treatment. And I think now it is available to drive an ablation, isn't it?
Well, this is an investigational device at this moment, and we use in two particular studies. One is in accommodative IOLs, topic which we have been investigating for years, and the second is in the new presbyopia drops that are coming out, just to see how much is accommodation, how much is pupil size, how much is pseudo accommodation, etc. And this is the main application. But on the other hand, in LASIK, and especially in touch-ups in hyperopic LASIK, is remarkable, you know, because we understand now why these undercorrections, why sometimes you have overcorrections, and the reason is that simply talking the influence of instrumental accommodation in the measurement, and this is important. Other way in which we are understanding the outcomes is in refractive accommodative refractive multifocal lenses with residual refractive errors. Sometimes you have difficulties in getting the right refraction. It's not a solved problem for me. Believe me, when I'm doing LASIK or PRK after a multifocal lens, I have much worse results than average, in spite of what is published. And definitely, this influences my opinion about these procedures and its indication. Now, with the open field aberrometry, we can rely much more in the refraction that we get, because we base the treatment refraction obtained from the open field aberrometry, which is another way to understand automatic refractometry. You know, and so I really think that this device will substitute everything that we have about aberrometry in the market. Number one, because a pyramid aberrometry is much more accurate. There's no way to compare with Cerning, which is definitely out from the market, or Harman Sack. It's much more accurate, much more reliable. In open field aberrometry, it doesn't have instrumental accommodation as an influence in the study of accommodations and refraction as well. And in general, it helps a lot to understand better what we are doing and what we have to decide to do. So I'm very happy. You know, it's a spectacular device, and definitely it's an acquisition as a refractive surgical tool, not only for corneal refractive, but for intraocular refractive surgery as well.
Okay, thank you so much. And we are looking forward to see that device, you know, in clinical practice soon, hopefully.